health information technology. So really, I think it has turned out to be the prototypical regional extension center. The workforce, there's probably about 40 people that maintain and help implement and support provider practices. So those three groups, if you look at what we've done, we touched probably about 2,000 providers in the Hudson Valley. I think most, if not all of those, they're all on certified electronic health records, and I would say that most, if not all, will make meaningful use in 2011. Probably about 1,500 of them use the health information exchange that we developed. A couple of counties, it's not fully, the hospitals are not fully integrated yet, so it's not used as much there. In terms of patient-centered medical home and transformation, of our primary care providers, of those 2,000, about half of them, over 300, we were able to get to level 3 NCQA recognition in about an 18-month period. So clearly they're really using their electronic health records. There is, as they've become more and more sophisticated and with more robust usage, there's been a screaming need for connectivity between providers. We're very interested in the direct project along that line. Our health information exchange, we believe, complements that. We see it used differently. And then lastly, we are entering into a project with Geisinger, taking their Proven Health Navigator program, which is really robust patient-centered medical home, and using embedded care managers. So we've had several that have been out training at Geisinger. We've been working on the program for about 6 months. Those embedded care managers will be going into play July 1st, and they will be targeted at the most expensive, most complex patients, and we've chosen our best performing patient-centered medical home practices for that, and we're very excited about that. Lastly, Think runs a multi-payer value-based purchasing program. The 6 health plans and 1 large employer in the region are participate in that. I think last year they paid out about $1.5 million to some of the medical home practices. That'll probably double this year. And they're wrapping the embedded care manager program into that project.
Thank you, John. And Kimberly, can you tell us a little bit about Sandlot, please?
Sure. My name is Kimberly Elise. I'm the Chief Executive Officer of Sandlot, and I'm relatively new to the company, actually the past couple weeks. So previously, I had co-founded a company called Empower Systems, which is clinical documentation. Started out as a best-of-breed emergency department product, and we built an ambulatory and full-blown inpatient. So, you know, as a best-of-breed vendor, I get the need for connectivity, and I'm excited about you know, where HIE is going. So Sandlot Connect is a comprehensive HIE with all the services that surround it. So we're really trying to target hospitals, health plans, IPAs in various stages of adoption. We get that not everybody's ready to move. We're actively developing products and services to reach people in the various phases of growth. And one thing we do, I think, a little different is we actively help with EMR adoption. And so I think one of our points of uniqueness in the market is that we're able to leverage our active physician usership. So we're a wholly owned subsidiary of NTSP, which is North Texas Specialty Physicians, and that is a family and multi-specialty practice company that manages 30,000 capitated lives. So we, you know, part of our model is certainly to help them, as also our biggest client, realize cost savings and enhance patient care. But with that comes something that's very great, which is very involved and engaged practicing physicians using our product every day. 65,000 clinical transactions daily. So it's really, you know, kind of a luxury that we enjoy to have that input, and that's very key to our mission and our growth, which is that active physician usership and a great user experience that really focuses on user friendliness. We really look at clinical workflow. Our plan is certainly to expand our footprint in the Dallas-Fort Worth area, but also, to seek the challenges and opportunities in other markets. And along with that, we're actively developing some new products. Now that we have all this data, there's, obviously everyone's been talking about analytics, and we're looking to really create something with value that does merge operational clinical data with point of care. So the ability to really look proactively and identify patients who might be at risk, to do decision support at the point of care, and then to use core measures like PQRI and HEDIS to do the historical reporting that's so important. Thanks.
Thank you, Kimberly. So now I'd like to turn to our participants on the phone, and I want to start by calling on Michael Matthews. Michael, are you with us?
I am, Kate. Thank you. Greetings, everyone. It is my pleasure to join this esteemed panel, and I thank you, National eHealth Collaborative, for putting together this significant project. I think there are a lot of successful stories in health information exchange that need to be better told, and you're playing a great role in doing that. I'll give you a few data points on Med Virginia. We've been in operation with our health information exchange since January of 2006. At this point, we have about 1.5 million records in our clinical data repository, as well as an increasing number of federated nodes on our system as well. There are a couple of things I would like to highlight. Certainly, a lot of the attributes that the others on the panel have mentioned are great critical success factors. I'd like to point out the importance of the Nationwide Health Information Network and our participation in that as far as meeting our strategic goals and objectives. Some of you may be aware that Med Virginia was the first to go live into production through a partnership with the Social Security Administration, and that particular use case has been well chronicled. There was an independent case study on our work with the SSA and the value proposition, not only to the patients who are going through a disability claims application process, but also to the providers and to SSA itself. So we're very pleased to have been part of that initial work. Also, very pleased and proud to participate in the virtual lifetime electronic record, along with our colleagues from the VA and Department of Defense. That has been one of the most gratifying initiatives I've worked on in my 31 years in healthcare. Our project in Hampton Roads region, Virginia, went live in October and has now rolled into the Richmond area as well. Just from a mission standpoint, we have an ongoing key message point around leaving no patient and no provider behind. And so for us, being able to address the needs of the chronically ill, the disabled, and our wounded warriors ranks right up at the top of our strategic imperatives. And through the partnerships that we've had regionally as well as nationally, I feel like we've made a lot of strides. So again, it's exciting to be part of this process. I get a lot of visibility in my role on the Nationwide Health Information Network Coordinating Committee about the fine efforts that are going on around the country. And again, Kate, thanks to you and NeHC for leading forth this charge.
Thank you very much, Michael. Dev Culver, are you with us?
I am, Kate. Thank you very much. Hi, I'm Dev Culver. I'm the Chief Executive Officer for Health InfoNet, which is a private 501c3 organization in the state of Maine. We are the designated statewide health exchange for the state. Health InfoNet is a stakeholder organization that was created in 2005. It represents the 5 primary stakeholder groups, including consumers, providers, government, business, and payers. At this time, we've been operational for just about 3 years in terms of actually supporting clinical care. We have just about 67% of the population of the state is in the database. That represents about 900,000 people, give or take a little, out of 1.3 million. We are connected at this time to 16 hospitals and 4 group practices, and are growing this year by another 8 hospitals, which will get us up to basically the vast majority of care delivered in the state, because many of these hospitals in Maine are actually the anchor for the primary care structure in the state, too. So when you get the hospital, you also get the primary care physicians in the structure. We are currently based on a sustainability model that is both part subscription and part contract. We do have a fair bit of federal money flowing through us right now as a result of the HITECH Act and the HIE grant program. But that money will soon disappear. And so our focus in sustainability is now moving over into some direct value services. We have 3 separate ACO efforts going in the state, and we are remaining neutral and trying to be a critical information provider, both in the real-time care component and in the near real-time and analytic component for supporting analyses. We're working with an academic institution right now to build out and finalize a predictive modeling structure that will enhance some of the ability to look at populations both from a cost and clinical outcome perspective. And we're actively engaged in one of the 17 Beacon Community grants. We're the primary contractor to that grant, connecting the community of Bangor, Maine, to focus on 4 chronic care conditions. That project is going along terrifically. We brought up the other hospital in town a couple months back, and we already had 75% of the people in the database that were registering into that organization. So there's a very high probability we're going to see some real impact. That is, as was mentioned earlier with the conic, that is a care management approach where each of the organizations is committed to providing clinical support through dedicated care managers. They're using the exchange as the basic vehicle to manage on common standards within those 4 areas of chronic care. And the exchange is really serving as the vehicle to connect both the information but also provide some of the automated interpretation of that data. Going forward, our state plan is to have all hospitals connected by 2015. I think we'll actually be there by 2014, and to have 80% of the provider community connected by 2015. Our growth objective really will be the database itself. Maine is unique in one respect in that it's one of only 6 states in the nation right now that has an all-payer claims database. So the process of being able to marry up the claim with the clinical activity is coming along now, along with that analytic effort. We're also looking into some other opportunities. For example, one of the value-add propositions is to have the exchange become the prescription medication program for substance abuse in the state in terms of supporting what is now an independent and separate portal strategy by bringing that into the exchange. Not only do you get the added advantage of having the other clinical data, but you get another advantage, which is in addition to seeing prescriptions that may be signs of medication shopping.
The caller,
Tom Dees,
has left the conference.
You also get to see the shopping behavior while it's occurring as a result of the registration and office visit information that you have. So we continue to look for opportunities like that. One of the projects we're going to connect up with here this year involves the patient-centered medical home initiative in the state. We're one of 8 states funded through CMS for that right now, and we're going to look at an ED visit notification process with follow-up tools so that we can begin to impact on what is a very expensive and high-volume transaction activity in the state, which is overuse of our emergency room structures. So that's basically what we are.
Very good. Thank you, Dev. Next, I'd like to call on Tim Cromwell. Are you with us on the phone, Tim?
Yes, Kate, I'm with you. Can you hear me okay?
Yes, we can.
Okay, thank you, and thanks for the invitation to present today. I'm Tim Cromwell. I'm the Director of Standards and Interoperability for the Department of Veterans Affairs, Veterans Health Administration, and I am also leading the health information exchange activities with the private sector, including the Nationwide Health Information Network and the VELR Project, Virtual Lifetime Electronic Record.